Okay, so let's start with the first debate of this CONy 2019. And there's going to be a series of exciting debates in the coming days. And to start off the first one, our host today is Professor Joseph Masdau. He leads the NANS National Alzheimer's Center and Neuroimaging at the Houston Methodist Neurological and Research Institutes, and is a professor of neurology, Weill Cornell Medicine. He has been professor of neurology at the Albert Einstein College of Medicine in New York and chairman of neurology at the New York Medical College. He is chairman of the Neuroimaging Research Group of the World Federation of Neurology. He has been the director of the American Academy of Neurology and president of the American Society of Neuroimaging, as well as the editor-in-chief of the Journal of Neuroimaging. So over to you, Professor Masdau.
Thank you very much. And I promise to contribute so that you are out of here by 6. But let me say something, which is that I'm delighted to be in Madrid with Professor Korczyn, this beautiful city where I was born. And the last time we had lunch was actually in Barcelona many years ago. So my father is from Barcelona, and I wish that politicians in Spain looked after their people, as they are doing, but also they further unity for everyone and the universal spirit of Spain. I mean, I was very happy to see in The Economist a couple of weeks ago how Spanish economy is going great, and how all the wonderful things that are happening in this country. So delighted to be here. So let me move on to AD, and the question is AD a useful term? Well, why are we saying this? Or why are we thinking of this?
The yellow thing. The right side? On the screen? Right side?
There you go.
And point there, okay, because the techniques are...
Thank you. Thank you very much. All right, these are my disclosures. I do have some interest in particularly neuroimaging stuff. The traditional diagnosis of AD, we made it when somebody had cognitive deterioration, and it was likely associated with amyloid plaques and neurofibrillary tangles that we've been hearing about. But the point is that we don't have to wait for neuropathology to see plaques and tangles these days. We can see them with imaging tools. We can see them. We can see the status of amyloid by looking at CSF. So we know that things happen before the person has cognitive deterioration. And that's why this is a controversy in the sense that should we use the term preclinical AD or not? And I'm sure our speakers will bring both theoretical arguments and practical arguments why this should or should not be done. When I was at the Brigham, I took this slide here on the left. You have a plaque in the middle. You have neurons filled with tau tangles. You cannot see those things very well with MRI, but you can certainly see them with tau and amyloid imaging. This is amyloid. You can see the huge difference between an Alzheimer's patient and somebody who's healthy. Well, using these tools, we've been able to map the progression of these changes, the progression of amyloid, tau, impaired synaptic function, and finally atrophy through the time course of Alzheimer's. So here you have on the x-axis time, and we go from a preclinical stage to the point where we diagnose mild cognitive impairment. The person begins to have more than just forgetting where they put their keys. And finally, when they become unable to handle work or other things, then we make the diagnosis of Alzheimer's. Well, these changes happen in a very well-described pattern. We know that now very well. And this is the way it looks. So these bars represent the width is when the change is higher. And there you have in those little boxes the tools that we use to define them. You can use also, of course, these are imaging tools, but you can use CSF. And amyloid, for instance, we know now that it begins to deposit in the brain 10 to 20 years before the person has any cognitive impairment. All right, so a number of years ago already, the research guidelines that were put together by the way, and the Risa Sperling was the chairman of one of the committees, but David was chairing another committee of these ones. And we, in research, we've been working with these concepts already for almost 10 years now. So I'm not going to go through this in detail because you probably hear about it again. So now we are going to vote, and we don't want anybody abstaining. This is a very, very important vote. Is preclinical AD a useful term? All right, so get ready. And the first question, or the first group to answer is whether it is yes. Well, I suppose this is at the end, right? Whether they won or not. Okay, so very good. All right, so why don't we vote on the previous one? Is AD, preclinical AD, a useful term? And let's go on to the voting. Go for it. All right. So the yes is Dr. Knopfman, Professor Knopfman. The no is Professor Korczyn. And I suppose that's the timing. All right, okay. Well, let's see whether this stays the same after the discussion. You will be presenting the speakers, right? Or should I? You will. Okay.
Okay, starting off, is preclinical Alzheimer's disease a clinical a useful term? And to speak for that is David Knopfman, professor, and he's a 1975 graduate of the University of Minnesota Medical School. He did his neurology residency and behavioral neurology fellowship at the University of Minnesota.
You can be brief.
He's a professor of neurology at the Mayo Clinic College of Medicine. He's the immediate past chair and the medical and scientific advisory council of Alzheimer's Foundation. Over to you, Professor Knopfman.
Thanks. Well, thank you very much for inviting me to be here. And although I actually do very much believe in the position I'm taking, I really appreciate the opportunity to vet it in front of Amos and the rest of you. And I hope this will be a lively discussion. My disclosures are given here. There are none relevant, but I definitely have intellectual interests in this topic, and those certainly constitute my opinions. First point is that this debate really centers on what does the term Alzheimer's disease mean? And I would assert, and I hope there's no one in the audience who disagrees, that this designation that goes back to 1907 of Alzheimer's disease representing neuropathologically amyloid-containing plaques and tau-containing neurofibrillary tangles. I mean, the pathology is, the biochemistry is more recent, that is the definition of Alzheimer's disease. Now, what we're talking about here is a diagnosis that is made when people are asymptomatic. Now, there are many other examples in medicine. I just listed a few here where we deal with asymptomatic lesions that are pathological in people who are asymptomatic. And moreover, We've known for a long time, at least with carefully done studies, at least 20 years, that there in fact are a large proportion of individuals who are cognitively normal within 18, 24 months of death, who have fairly high burdens of plaques and tangles. Now, it's interesting that prior to PET imaging, this topic was generally, I'm not sure people believed it, and certainly no terminology was used to describe these individuals. And if the neuropathologist, with all due respect to my neuropathologist, said it was Alzheimer's disease, that was an autopsy, and nobody really argued about it. I would say that was because the conceptual model in the field that existed up until the mid-2000s really didn't allow for thinking about Alzheimer's disease pathology as occurring in the preclinical stage, that is, before people had symptoms. In 1984, the McCann criteria, the NIN, CDS, ADRDA criteria were published, and they had a tremendous impact on the field. As best I can tell, they really were universally accepted and still are widely used. But it turns out that this clinico-pathologic entity that these criteria proposed is far from perfect. There are many other conditions that I'll talk about in a second that are not an amnestic dementia, which is what the NIN, CDS, ADRDA criteria implied. Now, actually, if you read the paper, the authors in 1984 were very cautious. We readers, from that point forward, ignored them, unfortunately. So it became known from neuropathology, even before the imaging era, that there were a number of problems with this definition. The first is not all amnestic dementia is due to Alzheimer's disease. That's really one of the really big points. That has been known in neuropathology for since the early 90s. The imaging data that has come out of clinical trials embarrassingly has shown that many patients who were recruited into AD clinical trials in fact lacked amyloidosis. Second, even when there are plaques and tangles, this is going to be a point that's talked about tomorrow, there are other pathologies. So just saying that somebody had Alzheimer's dementia with plaques and tangles doesn't mean they couldn't have something else. And that's an important point for really understanding biology. Even though this talk is just about Alzheimer's disease, recognition that there's more than plaques and tangles is really an important point if we're going to move forward. Third, it's become known with disorders like posterior cortical atrophy and logopenic primary progressive aphasia that non-amnestic presentations are associated with plaques and tangles. And then, pardon me, finally, that patients with mild cognitive impairment, in fact, neuropathologically, don't usually have plaques and tangles. They have other pathology. And to think of MCI as an early stage of Alzheimer's disease is only appropriate in those people who eventually progress. Now, something else happened with this terminology, and that is it became used, and I use the word in a vernacular sense. In epidemiology, people began to use the word Alzheimer's disease even when they had no imaging. They had probably even no neurologic physician doing a diagnosis. Primary care physicians began to use the word Alzheimer's disease beginning in the late 80s without any knowledge of the 1984 criteria, and there's public policy issues. And the point is, the reason why we're having this debate is that I assert that this vernacular use and the fuzzy use of the clinical pathologic entity that was spawned by the 1984 criteria is why there's the confusion about what Alzheimer's disease is. we cannot confound syndrome and etiology. Dr. Grinberg talked about this. Some diseases it works for, like PSP. Some diseases, like CBS, it's terrible for. And Alzheimer's is one that it's not very good for. Syndrome and etiology have to be kept separate. Alzheimer's disease is an etiologic diagnosis. And I don't want to discount the importance of clinical diagnosis in establishing a cognitive syndrome. And even, but without biomarkers, understanding etiology can be very difficult. Now, we have clinical tools. We can see if people have a sleep disturbance, or if they have Parkinsonism, or if they have a history of stroke. And those are all relevant. But when we get in the preclinical stage, there's nothing other than a little dot there that you can't see where history makes a difference, and that would be in dominantly inherited Alzheimer cases when you get a history of a multi-generational family. But basically, if you want to talk about disease in the preclinical era, you have to have biomarkers. Now, as Dr. Mazdu fortunately indicated, the key issue here is what PET scanning showed was actually merely to replicate what the neuropathology had previously indicated, namely that amyloidosis begins to accumulate, amyloid begins to accumulate as long as 20 years before people become symptomatic. I don't have a similar slide for tau, but suffice it to say that 3R, 4R tau is very specific for Alzheimer's disease. It occurs, however, if you can see in the A-beta positive controls, a few people have some elevated amyloid. I might disagree, Joe, with your slide because it doesn't quite reflect the offset or disagreement between amyloid and tau. But point is, tau occurs elevated tau occurs in the medial temporal lobe and to a slight degree outside the medial temporal lobe in people who are asymptomatic. And that's just what the neuropathology has showed. So the point here, and getting to the debate, is that prior to the 2000s, we had to depend on neuropathology. Now, with PET imaging, we can look at people in real time, and with pathologically verified amyloid PET and tau PET, we can see these processes in real time. And the point is, really far beyond just this debate, that PET imaging and to a lesser extent CSF have really changed how we think about the disease over its time course. Again, with all due respect to my neuropathologists who only saw the disease in one dimension, we now have the opportunity to see it unfold over 20 or 30 years using biomarkers for a large chunk of that. And I just have to make this final point here. I'm talking about biomarkers. I'm a clinician. Clinical diagnosis remains exceedingly important, and you can't even have this discussion without good clinical diagnosis. So my point is that Alzheimer's disease is the combination, and I mean it as and, amyloidosis, beta amyloidosis, and 3R, 4R tauopathy in excess. That is the definition of Alzheimer's disease. And if you don't use a term like this precisely, if you use it in the vernacular way I was talking about, or if you use it with the clinical pathologic entity that came from the 1984 criteria, you will make all kinds of mistakes, some of which we've actually heard today. Assumptions that certain risk factors are risk factors for plaques and tangles, when in fact they're risk factors for cerebrovascular disease, diabetes being one of them. Enrolling people in clinical trials for an Alzheimer therapy when they don't have amyloid, meaning they don't have Alzheimer's disease. And third, that in the case that we're talking about here, the pathology, the pathobiology, living people, can occur in people who are asymptomatic. So It can occur, this terminology of Alzheimer's disease with plaques and tangles can occur, it can be used appropriately at any stage, whether people are asymptomatic or whether they are pre-symptomatic, hence why I believe that this is an appropriate terminology. So if you have both elevated amyloid and elevated tau by PET imaging, that is Alzheimer's disease, regardless of your clinical syndrome. Now, I just want to mention briefly, and this came up, first of all, elevated amyloid without elevated tau in the new criteria, and I agree with, is not Alzheimer's disease. It is, however, probably on the Alzheimer's spectrum because amyloidosis leads to elevated tauopathy, and therefore it's part of the same process. By the same token, I don't believe that part tau elevations without amyloid represents Alzheimer's disease. It represents a tauopathy. It's a little more complicated, but I'll leave it there. The other point is that normal people with elevated amyloid and elevated tau are at increased risk for progressing. This is not a benign disorder. Second, if you only have one of those, and I am doing this with neurodegeneration as the biomarker, but it's the same thing. I don't have a slide that goes long enough period of time or the data long enough that I can show this. If there's only amyloidosis without neurodegeneration, or there's neurodegeneration, presumably tauopathy, without amyloid, the risks are lower. And it's interesting that in living people, despite the issue of multi-etiology dementia being very important, people who are A negative and N negative, or A negative and T negative, actually have a pretty good prognosis. So, final slide. Alzheimer's disease, as a proper way to use the term, as a precise way to use the term, means elevated beta amyloidosis and elevated 3R, 4R tauopathy. And it can be at any stage of symptomatic or asymptomatic functioning. I believe that the fuzzy use of Alzheimer's disease to mean dementia or to imply that people are cognitively impaired is a mistake that's going to hold us back. And I just close by saying this upset me enough from other reasons that I won't go into now that I wrote a paper that's in press in neurology on this topic. And if you disagree, you can write letters to the editor. So in any case, thank you very much, and I wait to hear from Dr. Korczyn.
Thank you, Dr. Korczyn. Amos, and I think everybody knows Amos, who might argue both sides. He's typically Amos.
Yes, thank you very much. I regret that you don't introduce me.
Okay, I will introduce you.
And then I'm going to say, to quote Mark Twain, who said, I'm always, apprehensive about these introductions, like the ones that you make, because there's so much more to say.
Okay. Amos Korczyn from Tel Aviv University, where he's an emeritus professor, organizer of this meeting, and is an advocate for almost every position you could have in neurological sciences.
As I said, there's so much more to say.
Okay.
Okay, so thank you, David, for proposing the conventional approach. And I traditionally like to shake the boat a little bit, and I will tell you why I think David is wrong, not for the first time and not for the last time, but this time I have an easy task to convince you that he was wrong. So what is preclinical disease? And you will see that David and I agree on the facts, but not on the conclusions. So, unfortunately, I don't have any conflicts to report. Would have been better otherwise, but the industry does not like my position, so this is the way it is. So what is Alzheimer's disease? So firstly, let's agree, and this was sidelined by David, it's not what it used to be. So when David and I went to medical school, we learned about Alzheimer's disease, and we learned about Alzheimer, and we knew what he called Alzheimer's disease, how he defined Augusta D, and he said that this is a pre-senile dementia, and he clearly distinguished this from senile dementia, which of course exists in Germany there as it is now. So the classical Alzheimer's disease is caused by dominantly inherited gene mutation expressed by amyloid and tau deposition, and therefore, and of course it's an orphan disease, it's a very rare disease. And now these sages took this name and used it for something else. And Alzheimer is all the time shaking in his grave. I mean, what did they do? They took my disease and said that everybody, all the old people or half of the old people have the same disease. No, my disease is unique. So they changed the definition. And rather than talking about juvenile Alzheimer's disease, or not juvenile, but early onset Alzheimer's disease, they have the new Alzheimer disease definition that David has mentioned of the sporadic disease, not the genetic disease, and it's a clinical pathological entity of progressive dementia with specific neuropathological changes. So here David and I agree. What I would stress, however, is that this definition is a complex definition. It's not a clear one. This is a unique definition of a disease where you require the clinical manifestations and the pathology to define the disease. There is no other disease in which the textbook definition requires the combination of the clinical manifestations and the pathology for the reasons that were given by David. But this is remarkable. So now we come back, or make forward or backward for the third definition of Alzheimer's disease, which is of the preclinical stage, which is the pathological entity without clinical manifestations. This is, again, against what has been mentioned before or agreed before. So, in other words, preclinical Alzheimer's disease, I'm sure you have you've heard it from David, it's an asymptomatic brain amyloidosis. This is what it is, and tauopathy as well. So, asymptomatic brain changes. So we know about the amyloid and we know about the tau, but I maintain that when David said that some dementia are due to plaque and tangles, this is an implication. This is a theory. Nobody has proven that these changes are due to. They're associated with these pathological changes by the definition. But to say that they are caused is an assumption. And this assumption has so far not been proven. And in fact, as has been mentioned just recently, the fact that again and again failure to improve the clinical manifestations by taking away amyloid, removing amyloid through various ways, this proves to me the clear association of amyloid or tau with the neurodegeneration. So we are going now back 25 years to Hardy and Higgins that say that Alzheimer's disease, they put in the amyloid cascade hypothesis. Hypothesis. And 25 years and nobody has been able to prove the hypothesis. So how is beta amyloid related to the sporadic Alzheimer's disease? I'm not talking about the early onset genetic form. So is it just a manifestation of aging? And I think we all know, and everybody would agree, that amyloid accumulates in the brain of older people. As they advance in age, there is more amyloid there. Whether they reach a threshold, this threshold or that, that's a different story. But this is what happens. So you can ask that this is just an epiphenomenon, or that it's even, and people have suggested that maybe the amyloidosis is a protective stage or protective reaction, or maybe it's a partner in crime. But I think that it's important to note that if we look through the microscope, and we see the amyloid and plaques, as the pathologists do, looking through the microscope gives you a very interesting picture, but not the whole picture. It limits the view. And the whole picture of amyloid, of what we call Alzheimer's disease, let me remind you, is not the deposition, but the fact that there is degeneration, that there is loss of tissue. Not that something is being added, but that something is being lost. So in these definitions of the disease, what about cell loss? What about synaptic degeneration? What about white matter changes? And you've heard Leah Greenberg just before, so this is another of her papers published a few years ago, which shows, and she's not the only one to show this, that it's not the amyloid which is important. What is related to dementia is the cell number changes. So this is the important thing, the neurodegeneration, rather than the deposition of plaques and tangles. So the assumptions that A-beta deposits predict Alzheimer's, the appearance of dementia, this is the next stage that David wants us to believe in, that this will predict this. So in this, therefore, what he said, and he said it clearly, that actually we're talking about amyloid or tau or combination as biomarkers. So these are biomarkers of a disease. So we had many studies. We've been in a meeting last week on ADPD, and there were several sessions there about biomarkers for Alzheimer's disease. So here is another marker. So is this a good marker? Is it an excellent marker? Is it an obligatory marker? What about other markers? What about age? Because we know that age is related, as I mentioned before, to brain amyloidosis. But it's related also to dementia. So the frequency of dementia, of course, increases with age. What about genetics? What about ApoE epsilon 4? What about vascular risk factors? What about neurodegeneration? So in order to convince us of the existence of these biomarkers, of amyloid and tau as biomarkers, we should ask ourselves, are they any better or not as good as the other ones? So I've not seen a paper that compares the reliability of these biomarkers, these imaging biomarkers that we've heard about, from these biomarkers, which we all agree. And I think this issue of age is very important, it's very critical. Because if I were to be shown a PET imaging picture of amyloid in a person who is 50 years old, no question that this person has Alzheimer's disease. If the person is 90 years old, I think David would not be very happy to call it Alzheimer's disease. He would not be very happy to say that this is predictive of the future cognitive deterioration. So this age dependency is very important and has been eliminated from this study, but from the conclusions that David brought. So as he said, there are many people who have deposits and who will never develop dementia. We don't know that these people who have amyloid, 30% in the large clinical studies in North America. And very importantly, even if we accept what David told us, so he says this is predictive of developing of dementia, and the patient who will come to us will say, predictive, what do you mean? Will I develop dementia tomorrow, next week, next month, next year, in 10 years, in 20 years? And we don't have any data on that. The data that were shown showed us that in 10 years, what David has shown, maybe 40% of them will develop dementia. And we don't know that this will increase further. Maybe it will stabilize on 50%, and that's it. So I would just want to mention about this issue, the first slide that David wrote to say that, to show that brain amyloidosis is like cancer. And if you see a cancerous lesion, you have to remove it immediately. And the same is true for amyloid. That's not what we are doing. We see all the time patients with carotid stenosis. And we know that this is a progressive disease. And the patient has a stenosis of 10% or 20% or 50% or 60% or 80%, and we don't do anything about it. So we don't necessarily attack any clinical thing that will likely or possibly cause clinical manifestations later on. So also, I think it was not clear in what David said, is that we should exclude other things. So it's not enough to do the amyloid testing. So if this person who was amyloid positive and tau positive, and I will show you his MRI, not his PET, with a lot of vascular changes, then David will say, this I don't know. That's too complicated. This person has multiple disorders. And many people at that age have coexistent pathology, which should be taken into account. So I think for me, preclinical AD is a dangerous diagnosis. We cannot predict on an individual level, as opposed to the statistics. We cannot we cannot predict on an individual level whether a certain given person will develop dementia and how long it will take him to develop dementia. So what's the use of making this diagnosis? So if this is a biomarker, then for any biomarker, any test, any laboratory test that we have to know what is the false positive and what are the false negative results. There are definitely in each laboratory test, and this one cannot be excluded, must have positive, false positives and false negatives. So if we don't know what are the false positives and the false negatives, how can we use it in the clinical practice? So why make this diagnosis? So is it scientifically validated? I hope I convince you that it's not. Is it useful to the patient? So after all, we want to treat the patients. Is it useful to the patient? No, no. Of course, primum non nocere. So what makes making this diagnosis, of course, will increase anxiety. So if David will take me to the PET scan and will come the results and will show me that I have a lot of amyloid and a lot of tangles, maybe I will develop anxiety. Maybe I will not sleep well. We heard about the consequences of not sleeping well. Although he will not be able to tell me whether this will my present condition will continue for 10 or 20 years. So it will increase the anxiety and may impair the vocational abilities and the insurance prospects. Who will insure me? If I have to show on the record that David showed that I have amyloid and tau in my brain, although this may not have any clinical implication for 10, 20 years. Nobody will give me a job. Nobody will insure me. So it's a dangerous, diagnosis to make. So in conclusion, preclinical AD defined by A beta and tau is not a scientifically validated entity, and the term should not be used in clinical practice. Not that we should not look at patients and examine them in various ways, but it should not be used as a clinical diagnosis for individual patients. So, is preclinical AD a useful term? I hope you'll agree with me now that it's not. Thank you very much for your attention. And
we have a few minutes for discussion because of my overly long introduction of Amos. Yes. You would like to come up? Right in front of you.
Amos, I think your job has become much easier since recently, much easier. First of all, historically, Professor Alzheimer never said that there is a causal relation between A beta and the disease. Actually, if you know German, in German he say the opposite. He doesn't say there is none. He says there is none. So this is historically too clear. Secondly, the experiment has been done over and over and over. As of a week ago, we know that if we do the experiment in human, we take 800 patients from MCI to severe Alzheimer, and we administered an immunotherapy which is able to delete completely 99% of plaques, and A beta does not exist in this brain. Now, as it was reported by the people who did this study a week ago in ADPD, we looked for a signal. There was no signal. Therefore, there was no effect. So one thing has been established, that the cascade hypothesis has to be revised considerably, if not canceled forever. Thank you.
Thank you.
David?
Yes. I want to make the point here that, first of all, I obviously agree. I was an aducanumab investigator, very disappointed. I will say in public very shortly, in a very open way, that I am not an advocate of any more amyloid therapies either. I agree with you. I agree with both of you. But I think that the distinction between using the words for diagnostic purposes and thinking about therapeutic options are two separate things here. They need to be separated. And I thought we were debating terminology. I really would not have taken this position if we were talking about therapeutic interventions.
Hi, Roger Burke from the UK. I voted Remain. Actually, no, I voted no. I voted no for two reasons, and the debate reinforced it for me. First of all, if Amos is right and NCO is right, then amyloid is not the pathology of Alzheimer's disease. And if amyloid is not the pathology of Alzheimer's disease, it's a biomarker. And if it's a biomarker, then we do not call or give people statins and talk about preclinical stroke or preclinical cardiac arrest. So if it's a biomarker, it loses its status.
How do you diagnose
Secondly,
Alzheimer's? How do you diagnose it?
Clinically. No, I mean,
That's dementia.
I do the same. I mean, actually, I don't actually see patients anymore. I would do the same, and actually the study we're doing is CSF, so we are putting in Alzheimer's as by criteria. I just don't believe them, as you're going to publish. But the second point I was going to make is that, as you said in your closing slides, David, if it's true what you say, it's true at all stages. So preclinical, actually, in terms of English, just becomes redundant. So it's not a useful stage. You've either got what you believe or you haven't. And then you have to explain to people what that means. And then, as Amos says, that's very difficult because we don't know what it means because we don't know what these people are going to be like in 15 years' time. So I think the answer is no, because it's confusing. We can talk about diagnosis later on.
Okay, another comment?
I am Professor Magdi Aidarus from Egypt. Thank you, Professor David. Thank you, Professor Amos, for interesting lectures. I agree with Professor Amos. If not treated, why support this preclinical? My question to Professor David, are you treated preclinical?
I failed to mention that, again, I was talking about definitions. I was not talking about using this in a clinical sense. I never would diagnose somebody with preclinical Alzheimer's disease other than in a research context for a clinical trial. I am not talking about saying this to patients. The criteria for amyloid imaging in the US are very clear. You don't tell people the results if you do them, and you don't do them except in a research context. So if people thought that I was telling my patients that they had preclinical Alzheimer's disease, that is completely erroneous. I thought we were talking about how to look at this problem scientifically in living people in real time that we can study with biomarkers.
But there are people claiming these tests for non-study patients. I know when
but there are lots of charlatans out there, George.
Yeah.
And that
I won't say, but
offer
a
all
city,
kinds of diets too.
Yeah.
That doesn't make it right.
Okay, I visit other cities in Texas, not in San Antonio. When I go to Houston, I see it on television. I won't say what hospital, but it's a prominent one. Amos? I was surprised you were quiet for so long. It's almost a record.
Unless there are more issues to be raised. So, so please, you want to say something? So please.
First of all, thank you for very provocative, very interesting deep battles. But my question is very concrete. Should we perform, in the case of our suspicious, very subjective one, investigation of CSF or PET or other possibilities? Because otherwise, how can we eliminate this group from research point of view, from the practical point of view, and from the point of view of the general approach is a very great burden? Thank you.
So I want to okay, please.
Do people think that the understanding of these changes and the progression hasn't given us any insight into this disease, or is we are the same thing that we were 30 years ago?
I think neuropathologists actually understood most of these points, although maybe they were esoteric.
They weren't understood by clinicians.
I know.
So, so it's an interesting issue that was raised here, I think. For a long time, the camp of Alzheimer researcher was divided into the Baptists and the Taoists. Those who believed in beta amyloid, Baptists, and those who believed in Tau as the Taoists. And the Baptists won for many years, and they won because they had more money. Why did they have more money? Because the industry supported them. Why did the industry support them? Because they were hoping that the anti-amyloid therapies will work. Now, as this hope is diminishing a little bit, the Tau group is increasing. Now, what I'm seeing in what David said, a slight retraction from the position of beta amyloid as an important target. So it's a signal that is there. And I think that this is a very welcome change, that amyloid can only be a signal, and it's a stronger signal if it's enhanced by Tau. But I would ask you, I gave this example of this person who's amyloid and Tau positive, but has a lot of vascular changes in the brain. Would you still call this person having Alzheimer's disease?
You would say Alzheimer's disease with
okay.
cerebrovascular disease.
All right, so this person